I'd just like to introduce Leanne Smith as well, who's going to join the panel. Are you comfortable on the... Oh, we've got another chair, lovely. So Leanne is the Clinical Nursing Director of the Refugee Health Service in Logan. So I think we will have... and Meryl is our Nurse Unit Manager for the Mater Integrated Refugee Health Service, who will be helping with the panel. And Vicky has a roving mic. And for those of you videoing in, if you have any questions, as we said before, just write them into the Zoom and we will get them into the chat. Thank you. Okay. Questions, anybody?
Okay, forgive me if I get your name wrong. Is it Julian?
Yeah.
When you were talking about the 90-90-90 goals, you mentioned that some people actually don't want to have treatment. Can you give us some insights about why that might be?
Well, I mean, it depends on everyone. A lot of people look at even though they completely understand that they've got a virus and that this virus is part of their...
Julian, sorry, you just need to use the mic because otherwise the video...
Is it working now? Hello? Hello? Yeah. There we go. So it just depends on what someone's personal belief is more than anything else. So some people acknowledge that, yes, they've got HIV. Some people don't acknowledge they've got HIV. But a lot of people say, well, look, you know, irrespective, I just don't believe in chemicals. I'm not going to take those. I'm not going to poison myself. And we have a number of people who say, look, you know, if I get really unwell, I'll come back and listen. But at this present moment, I'm feeling absolutely fine. I respect that you're coming with my interest, but however, it's not what my choice is. And also, some people have just never really, have been on and off medication, their lifestyle's quite chaotic. And they really know, they say, well, look, you know, I'm not in the right place at this time to take it. And so even though, you know, the thing with HIV is your immune system's an amazing thing. The drugs suppress that virus, so when it's suppressed, your body gets on and does what it's going to do. And half of the time, the book is really sort of saying to someone, it's not just about you, it's about everybody else. You know, are your concerns, are you worried about passing it on to someone else? What do you really want from this? And quite often you can it's a relationship, getting people back on a regular basis, but you know, I'm not there to be a pill pusher, and I do respect people's views. Thank you.
I've got two examples of some of the motivations. There was certainly a person, it was a lady who we had, when I used to work in the same clinic as Julian's, who had arrived here very unwell. And had AIDS, had lost more than 20 kilograms in the past year. She was, you know, a young woman, but she looked like an old woman. She was so unwell. She attended the clinic, she got onto treatment, she recovered entirely, she looked fabulous, she felt well. And a couple of years later, she returned to her country of origin, and whilst she was there, she went to a religious retreat. And she told me when she came back that at the door of the retreat, everyone who went didn't have to disclose any medical conditions, but they threw their medications into a bin because they went into the retreat to be healed. And it was a condition of their faith that they accepted that they were healed. And so when she returned, she wasn't on treatment, and so she elected not to continue on treatment. Another reason that I've talked to people about that is because people sometimes say, I'm well now, I've recovered, and so I'm not sick, why would I take treatment? And that is a difficult concept to explain sometimes. And I think that's the sort of where you can have a lot of time to explain to a person why a well person would take treatment. Like Julian said, why would you put these chemicals into your body when you're well.
On the flip side is that I have seen people who, which is very unfortunate, who have been so, their belief is so strong that they've actually passed away and put on palliative, and they've actually dealt with their choice for some time. That's often when the community patient actually.
So from me, the only thing that I probably want to add to that is that also there is a history side of it. So I'm going to mix a bit of the history and the clinical guidelines for it. There was a time where obviously HIV was prescribed. We give HIV medications to people when their CD4 quite below this, not quite below, just below the standard. And a lot of people at that time, when they were diagnosed and their CD4 were good, they had this time to think about their diagnosis and what it means to live with HIV and to be connected with people who have gone through the journey with the medications and everything. So there were that opportunities to connect and all that sort of thing and make an informed decision and all that sort of thing. Now, we're not taking away that agency to have that moment to think about starting treatment. We're still doing that. And QPP, we surely believe that, you know, everyone got their own agency to make a decision whether they want to be on treatment or not. But we're also aware that, you know, it's becoming easy, isn't it, to just start treatment. And your yes mean, and then the next thing they'll be on treatment, and this treatment needs to be taken every day and all that sort of thing. So, and then, you know, in my experience and also from a couple of clients, you know, they got into a point where they're kind of thinking that, why am I taking this? And that's okay. We'll just be there for them. We expose them to the accurate information, the right information. We answer any questions that might come up. And then after a while, people do come around and then decides to be on treatment again. Yeah.
I think I'll just add something small, especially where I come from, when your belief is actually stronger than believing in the doctors. There is this say that we say, God is greater than the doctor. And sometimes they choose not to actually take the medication because they believe God is going to heal them. Thank you.
I'm just going to have one more go, sorry. A lot of people that I've met who have been people with HIV live in family situation or shared situation where they don't have much privacy. And even, you know, their drawers or their handbag or something, it's not really private. So sometimes people just don't want the tablets to be there because it would disclose their HIV status. So sometimes people will be on treatment when they're away from home, but when they go back home, they have to stop the treatment. It's just another reason.
I think we have to change our new drugs in the market, which we will in a couple of years in the
Are you talking about injectables or?
probably going to be a little plastic pellet in your skin.
Sorry, Julian, would you mind just repeating that?
The medication's changing, technology's changing, and even our knowledge and what we use these days for antiretrovirals. But within a couple of years, we're going to have injectable antiretrovirals, which you would need an injection maybe every 4 months, and it's going to move further than that with some of the newer drugs. So it might even be just a little plastic capsule under your skin every 6 months or even every 12 months.
Great. Yeah. Any other questions from the audience? Vicky?
I have a question for the representative from the G11. You mentioned in the opening session that even now in Australia, the community group that you're from still has a lack of understanding about the transmission of the virus. If you could have, you know, endless money, what would you like to do? What do you think would answer that question for a community living in Australia, in Brisbane City, to to still not have that education, what would you like to see for your community?
I think I would still push on with the education to tell the community that it's not a death sentence anymore. You can still have a very good long life and being HIV positive. So it's not like in Africa when you're HIV positive, people think you will die very soon. You can still live a very long life. So you just have to be ready to take your medication, as the doctor said, and just live your life. It's not that death sentence anymore.
Just going to add to that, because I hear that questions a lot, and sometimes I feel like that's a one big loaded question, isn't it, to ask to one person about what the community should do, or what we want to see is change from our community, and sometimes that can be difficult. I kind of actually starting to see a role of organisations like QPP and also clinical services to actually conduct a proper, appropriate, culturally safe community consultations and collaboration that utilise interpreter services that are truly private and confidential to actually look at and link experiences from different people within that community and start developing services and interventions and educations that can actually address the community. Because if we're not doing that, we're running the risk of we're trying to depend on the same person from the same community again and again, but that person, like myself for example, cannot speak to the whole of gay Asian men, and I will never ever be able to do that. And so I think when it's
it's difficult. Another thing is because stigma. So some people, like if we do workshops and invite people, and people would say, if you go, you probably have HIV. So that's how hard it is. So I think have to be targeted, response, and depend on the community you work with and what kind of resource in that community, and do they have like the radio or newspapers or what social media they use. It really depends on which community you target, and I think it's very complicated, and so that's what I think. That's why we like lots of research. Not lots of research, good research and good data. We know what's going on in the community. Be honest, Australia has low HIV infections, and compared to lots of countries, we are doing very well. So we just want to do better. So I think late diagnosis, I think probably the main problem, called communities, that people don't know they have it, infected for a long time. So are they infected here or overseas? So what's the factors? What's the risk factors? And I know PrEP is available, but I still strongly advocate for using condoms. Just because of STIs. We have to think about the STIs, not only HIV. We know that STIs are actually increasing in Australia, in Queensland. And how can we prevent STIs? Use condoms, and people are traveling back home. So how can we reach these people and let them aware of that? Condoms in overseas, in lots of countries, are not good quality. So simple like that. And we have to target these people as well. But anyway, so yeah, that's what I think.
And I think one thing that we said here with PrEP, which is pre-exposure prophylaxis, it's within Australia, for instance, it's probably had a little bit of an impact on HIV transmission within the Anglo-Australian population, but it's not had impacts in other communities. And that includes Indigenous communities. So it is really about getting, that having something which, yes, is a proof of concept, but it doesn't mean that it's going to be a proof of concept for everybody.
I'm not sure about that because we haven't seen the proof yet, but in fact we're seeing a lot of our people who are going overseas who are really keen to use PrEP, and I think we are going to be reducing in other communities the amount of HIV that we see. I have been astounded by the uptake of people who are just first time hearing of the options of using PrEP, and so I think we are yet to document it, but I think it is already having positive benefits for other communities.
I'm not sure. I mean, if you're talking about places in Africa, South America, the amount of resistance to what we use as PrEP is huge. And I think you've got to be a little bit careful of what we classify as PrEP and what's going to be adequate treatment.
I'm just going to add one thing is that, coming back to that kind of different strategies that we have, because we basically in the this modern age, like prevention for HIV, there are a lot of them, and so I think when we do, coming back to my first suggestions about doing a proper community consultation, I think we will see that messaging for different populations will work differently. So for example, if we talk about the culturally and linguistically diverse communities, and then we talk about the refugee, and then we talk about the refugee woman, and then we talk about refugee woman from sub-Saharan Africa, the messaging is going to be different, for an example, compared to like the gay Asian men, obviously. So this kind of tailoring needs to happen. We do have the resources, we have been doing that, but I think we just haven't, got the partnerships and collaborations and resources and funding all that supported to make that happen.
I think Meryl might... Oh, sorry, Jackie, were you about to...
I was only going to suggest that as one I would love to hear that the ministers promoted a positive message within the church, because a lot of people connected with the church or the community groups and the sporting groups, whatever those community groups are, if there was positive messages affirming, living well with HIV, and I think that would be one start, because certainly from the patient's perspective that I've spoken to, that's a huge influence.
Thank you.
Ask Julian, how do we refer our clients to you? I'm not sure if I've missed it before. Was there a referral form?
It's a good question. We have a terrible website, but all roads lead to the Sexual Health Centre. So if you do want to find us, we are open for business. We don't have a postcode lottery, if you're a GP we've got all our details within the primary care health network, health pathways. But we do have a website. It's not great, if you try a couple of times on the phone, you will get through eventually. But we will help you out and offer you advice if you get in contact.
I think we might have... Have we got time for one more question? Or
I just wanted to build on that one, just for other HIV services on the south side. So I noticed yours was on the north. So what are the referral options for the south?
So with the south, it's a much smaller centre, and it's run from within the hospital system, doing their outpatients. But what we do, I think they will also be open and be accessible. But it's just that they're a much smaller service and probably just don't have the capacity to get someone in if it was an urgent referral. We will always give people the choice. So whoever's referred to us, we will say to them, well, it's great you've come here, but you're going to get just as good a care. Why are you travelling this far to come? And quite often it's about confidentiality, and we have people travel, go straight past Ipswich, who will live out near Toowoomba or come other places, even people who travel up from the Gold Coast. So no, it's not about coming to Metro North, and hopefully we can start to provide actually a much better cover throughout the state through a sexual health network. But we would always tell people, yes, what's your nearest centre? And people quite often, because they've tried or they just feel about confidentiality.
Could I just ask a question? So hopefully that's okay with everyone. This relates back to our case study tonight and really just talking to Jackie maybe to start with. So when mum comes along with all her family and you get a notification for a help undertaking for mum, will you be talking to the GP about any other family members that are coming with her? And if not, what does that actually mean for clinicians in this space making sure that the GP tests everyone in that family unit?
Yes. So often we will either be working with a community support worker, but certainly it's about sometimes us liaising with the GP as well, because we would, or sometimes we would talking directly to the client. It's identifying how the client wants to have it managed, like the lady, the mum, and trying to assess, who may be contacts, who may need another test. Like Margaret said, perhaps all the people need to have a retest. But you need to pace yourself with that. We've certainly had a health undertaking for a man who did not believe he was HIV positive. So we went to see him, a phone interpreter, and then just happened to see a pregnant wife walking past in the background that we knew nothing about. So you've got a person who doesn't understand truly that is positive. It's a situation where it's really case by case. And in this situation, with their permission, we would definitely include the GP, because they need to have some local trust. But like Julian said, often people do want to bypass, they want to go to the specialist service, and sometimes it's the specialist service who might engage with the GP. I guess it's just our role is to try to help them get onto the pathway towards accomplishing all of the assessments and support that they need when they're ready for it, and having a primary sort of prevention, like a public health role, with trying to limit any risk to any other person.
I think every case is different, but with someone like this who's been diagnosed for 12 years and has been on medication, I think you'd be able to have a very honest and forthright conversation. And one of the questions I would probably ask, well, what are your biggest concerns? And it probably will find out it's the family, and getting everyone engaged in care would probably be one of the most important things. But you're right, it's everyone's different. But for this lady, I think we're 50% there already.
And just getting to a clinic, like with those children, getting into any sort of transport, safely and legally. There's just some really ordinary hassles to contend with, and I spend a lot of time, dragging people's car seats out of their car and putting them in our car, and, just to help, facilitate a person to an appointment. And please never underestimate transport. I just want to say that to you, Tika. That transport is not a taxi ride. Transport is an uninterrupted conversation that you can have with the client on the way to get some care. It is the best situation often to have those confidential conversations when you're both looking forward. So it's facilitating someone into care quite actively, but I think there's always a role for that sort of quite close support initially, particularly.
From our side, we can provide support services to couples, family members. We also have work with children cards, so we can work with younger people as well. And in each one of those situations, they'd have their own case, and we'd provide private, confidential support. In some situations, people do want to attend appointments and bring their partners with, bring family members with for support. And that works really well as well. So it's really what works for each individual person. If privacy is important, we do that. If they want support from a family member, we do that as well. So in this situation, it's not just having to offer support to one person, but if other family members wish to engage with our service, we're available to them as well.
From peer navigation side of it, it's actually about, in this case, probably about understanding about, like she's a single mother that maybe never ever have that time to actually learn from another single mother about how to be positive and managing kids that are positive, who are positive, all that sort of thing. And we have that peer navigator. And when that connection happens, magic happens. You suddenly get, someone who is usually very close, suddenly very open to talk about everything. So we sometimes get, situations where the client might actually be more open to the peer navigator, and that allows the peer navigator to refer to the appropriate services or work collaboratively with case managers or with HIV public health team to provide the best care.
Thank you. I think we could probably keep asking you questions all night, but we probably do need to wrap up there. So I would actually like you all to join me again and thank our awesome speakers for tonight.